felt okay to be in colored pants, and I asked some more, and it turns out he'd been hiding in his apartment, well, hiding really, because it was wintertime and everyone had colds, and it was freaking him out so much. So he was in his apartment washing the walls, and he felt like if he left the apartment, then he'd come back contaminated, and then he'd have to start washing all over again. So he just thought it was easier to stay in his apartment, okay? Well, lo and behold, I'm talking to him, and he's gone to register for classes, okay? So now that he's out registering for classes, he's seeing everybody do this, on the subway, and he's freaking out. So he comes to me and says, my symptoms aren't any less. And it's true, his symptoms weren't any less, but his avoidance was much less. So he was getting more triggered symptoms. So he and I agreed that we would wait a while. And sure enough, another 4 weeks went by, and he could see the difference, okay? So doses are high. Prozac 60, Paxil 60, Luvox 250, 300, Zoloft 200, Celexa 60. Did I forget anybody?
Lexapro?
Well, I'll get to Anafranol in a minute. Lexapro, we don't know. The drug reps are very cagey about the equivalence of Lexapro to Celexa. So they'll tell you that Lexapro, what do they tell you? I think they tell you Lexapro 10 is equivalent to Celexa 40, maybe. But Lexapro 20 is not necessarily equivalent to Celexa 80. So the bottom line of it is that we don't really know with Lexapro. We're ad hoc, with no good data at all. Ad hoc in our clinic, we're thinking Lexapro 30 is like Celexa 60, but you could have picked a different number. Okay. I'm talking all about adult doses now. Children are often dosed by weight as opposed to in milligram doses, because as you know, that age with a child doesn't necessarily mean anything about weight. In fact, I should emphasize that. I'm talking all about adults. I work primarily with adults. I do know about medications in children, but it's not my forte or expertise, so I'm talking to you about adults. Most of what we know about adults is applicable to children, except for with all the concerns about using medication in children. So that, I'll just, anyway. So typical doses, time to respond 6 to 10 weeks on these high doses. Now, important, what's a typical response? So the first thing is, between the SSRIs, comparative efficacy in the large randomized controlled trials. Caveat, we've seen patients who don't respond to Prozac who then respond to Zoloft. It doesn't make any sense. They're all supposed to act by the same way. They're all supposed to act by serotonin reuptake inhibition. It shouldn't work like that, but we've seen it, okay? It's not like we see it a lot. It's not like if you take all non-responders to Prozac and put them on Lexapro, you suddenly see 100% respond to Lexapro. But there is a small group of people, for reasons we cannot explain to you, that don't respond to one, but respond to another, okay? But in the large studies, when people say, well, which one do you start with? I don't have any data to suggest that one is better than another. What I do have a suggestion of, what we use to choose one SSRI versus another, is their drug-drug interactions and their half-life and their side effect profile. So things like Prozac can have much more drug-drug interactions with other medications. So if I have a patient who's on a lot of other medications, a lot of people will choose Celexa or Lexapro because Lexapro is thought to be the least like that. On the other hand, there are other considerations like half-life. If I have a patient who has a real hard time taking their medication every day, Prozac has the longest half-life, and it has a metabolite that has the longest half-life. So once you take a pill, it's in your bloodstream for weeks. Unlike something like Paxil or Luvox or Celexa, which has a much shorter half-life, so that you really, if you're not taking it every day, you can get into trouble, okay? So we as psychiatrists, I don't know how to choose one SSRI over the other. I use what people have responded to in the past or haven't responded to. I look at what other medications they're on and look for any bad interactions there might be. I consider the issue of half-life. And I also consider the cost. So huge advantages, there's no drug rep here, I hope. Huge advantages of Prozac is it's now generic. Luvox has gone generic. Lexapro is incredibly expensive. So there are also things like that. What I should say is Prozac, generic Prozac is inexpensive, but you have to be careful of the pharmacy you go to. My pharmacy can buy it for a couple of pennies a pill. So when I had a patient come to me who said that they went to, and I can't remember which pharmacy it was in New York City, so I don't want to cast aspersions, but it was either Duane Reade or Rite Aid. And he was told that it was going to cost him, I can't remember what it was, $7 or $10 a pill. I couldn't believe this. And it turns out that when just one company has a generic, they can still keep the price really up there, but as more and more companies produce it, suddenly the price plummets. So what I would say to you is that if you're trying to get a generic drug and it's very expensive and you have this sense of, well, wait a second, generic's not supposed to be so expensive, pharmacy shop. Go shopping around your pharmacy. But anyway, okay. Comparative efficacy of the SSRIs. The other important thing is in the large randomized controlled trials, and what that means is hundreds of patients, half get the drug, half get a sugar pill, and that's considered the gold standard. No one knows what they got, and they're evaluated blindly. That's like the hard way to test a drug. You get about 40 to 60% of people responding to the drug. It's not 100%. It's important to know that. Second thing is that the mean reduction in symptoms, what's a response? A 20 to 40% reduction in symptoms on average. Now, if you're obsessing 8 hours a day and you go down to 6 hours, or you're 8 hours and you go to 4 hours, that's a big drop. But unfortunately, it still means you're obsessing and compulsing 4 hours a day, so you're by no means cured. Now again, I want to emphasize this. These are means. It's not that I haven't seen a person on medication get a fabulous response from medication and be almost cured. Okay? I've also seen people on medication get no benefit at all. Okay, so this is a mean average response, but it's important to know that if you're educating a patient about their treatment options, it's important to let them know that they're not looking for the glass to be empty, they're looking for the glass to be half full, and that's a good response. Typical side effects. I mean, these are the common side effects from the serotonin reuptake inhibitors. GI symptoms like nausea or upset stomach, nervousness and agitation, particularly when starting it. If you've got a very anxious patient, as a result, you want to start very slow doses, and go up very slowly. Sexual side effects are the big bugaboo. I mean, they're just terrible. And you can have, in males, they report problems having an erection, problems having an orgasm, decreased libido, and women, the same thing. And I've had a lot of patients who've had wonderful responses to SRIs, and yet they feel like, my God, at first they said, oh, I'll take it, anything to not have my OCD. And then after 2 or 3 years of having a lot of marital problems with their partner, feeling like, well, gee, this isn't any way to live either. So, and we don't have a good answer to the sexual side effects, unfortunately. And then the final thing is discontinuation reactions. In SSRIs that have short half-lives, Paxil is particularly notorious about this, or paroxetine. If you stop your med, you can get a terrible, like flu-like syndrome from discontinuing your medication, bang. So it's very important that just as you go up slowly to get your body used to it, it's important if you're going to come off of it, go down slowly to get your body used to going off of it. The only one that really you don't have to worry so much about is Prozac, because the medication has such a long half-life in your body, it sort of tapers itself. Okay, this is just important to know is that these are from the research literature. Some OCD patients may respond less well to serotonin reuptake monotherapy. And the things that have been pointed out are hoarders, but hoarders respond less well to most things. Doesn't mean they can't respond though. And that's an important thing to maintain hope for your patients. I've seen a hoarder who had just a most spectacular response to clomipramine, and I've seen hoarders who've had spectacular response to cognitive behavioral therapy. So this, it doesn't mean you shouldn't treat patients with SSRIs. Chronic tic disorder, schizotypal personality disorder, these are people who sort of are odd, but not psychotic, but have, let's say, think they can read other people's mind, extrasensory perception, not very socially connected to other people. There's this thing called primary obsessional slowness, where people just can't get going. They don't seem to respond very well. They're not so unusual. It's not like they're very well represented in randomized controlled trials, but that's been another thing that's been pointed out. And obviously, if you have an OCD patient whose OCD gets caught up with their medication, it can be terrible. So if you have a contamination phobic who starts to get anxious about the fact that the pharmacist may have touched the pills in the bottle and then can't take the pill because of it, obviously that's something that's going to just get in your way, and you're going to have to find a way of working around that and working with a person so that they can get on the medication to hopefully then see some relief and then hopefully that lessens. So what do you do if an SSRI doesn't work? So the general thought, and there are no clear rules about this, but the general thought is you try one SSRI. If it doesn't work, maybe you try another one. And if that doesn't work, don't give up until you try clomipramine. The clomipramine should be tried eventually. Typical dose can be 200 to 250 milligrams a day. Time to response is the same, 6 to 10 weeks. Again, typical response, comparative efficacy with the SSRIs, although there's some meta-analyses, which is where everyone pulls the data. Clomipramine seemed to do better, but again, is that just because the samples were cleaner when those clomipramine studies were done? We don't know. Or is it because clomipramine is a slightly messier drug? We don't know. We have just finished this study that I told you about comparing cognitive behavioral therapy to clomipramine, and what you see up there is the response rates for everyone who studied. I can't see what that number says. Is it 42%? And people who completed the 12 weeks, I can't read the number, but it's about 40, right? Okay. And then the symptom reduction, what you're seeing there, and I can't read my numbers.
26 completer.
Great.
31% completer rated as a responder. 48%, but 1/3 had YVOCS.
Okay, so thank you, perfect. So the idea of this is if you completed 12 weeks of clomipramine, which is what you need to see in effect, and you were rated as having responded, what was your average reduction of symptoms? 48%. So that's like going from the 8 hours a day to the 4 hours a day. However, 1/3 of those people had YVOC scores greater than a 16, which is called clinically significant. They could have entered our trial at the end of our trial. Okay, so it's just important to keep in your mind. What I say to all my people is that OCD medication will reduce your symptoms. I hope it does more, but on average, that if you get that, we'll be happy. Oh, I'm sorry. Why isn't clomipramine used first? Because of these adverse side effects. In addition to all the other things that the SSRIs can cause, clomipramine can be toxic to your heart. Specifically, if you have certain types of arrhythmias, it can kill you. It can cause seizures in high doses. It can cause terrible urinary retention, sedation, dry mouth, constipation, postural hypertension, where you stand up and you get dizzy and you come down. So it's not a medication. That's why it's not used first. Have I seen people who've been very safely on clomipramine for many years? Yes. Is there a way to go on clomipramine very safely? Absolutely. You get EKGs before you go on it, you go on very slowly, and you get monitored very carefully. But it is a medication that you, in overdose, can kill you. So it's a medication that's why it's second line, or done second. It's first line, but it's done second. Now, is venlafaxine a better clomipramine? Venlafaxine is Effexor. Big conundrum in the field. Venlafaxine's mechanism of action, like clomipramine, is supposed to be both a serotonin reuptake inhibitor and a norepinephrine reuptake inhibitor. It's more venlafaxine at lower doses is more norepinephrine, and at higher doses, the serotonin reuptake inhibition kicks in. So everyone was very excited when Effexor came out on the market because, first of all, it can be a very good antidepressant, and OCD patients often have comorbid depression. But also, my gosh, could Effexor be like the better clomipramine without all the side effects? I mean, that's sort of the model, right? The problem is the data don't really support that. So while there's some positive case series and some open label studies, and open label means everybody knew they were on Effexor, and everybody who rated them knew they were on Effexor, there's only one placebo-controlled, randomized controlled trial, and it was negative. However, they only used doses up to 225 milligrams a day, and the trial only lasted 8 weeks. So it's very possible that they just didn't go to a high enough dose for long enough time. Okay? It is true that in that study, something like 0 out of 14 placebo patients responded, and 7 out of, I don't remember how many it was, 16 OCD patients responded. So it does look in the data that there's something that might be there, but no one's ever followed that up. I've tried to get the Effexor company interested in that, but they're not interested. Now, there's some more recent studies which are with poorer methodology, but again, keep this question of Effexor alive. So there's a study of, I can't even read what it is, but I know that there are 2 studies. One is a study by Hollander in SRI-resistant patients, where he took people who hadn't responded to a prior SRI, stuck them on Effexor, and got very good percentages. It's something like up to 60% or something, is it? I can't read the exact numbers. The problem, Yes, exactly. I mean, like this whopping response rate in SRI-resistant patients. So whopping that one thinks, is that really true? Meaning, you don't even get 75% in a regular randomized control trial. So the thing is, I guess what I'd say about these studies is they're suggestive. We think Effexor should work, right, by its mechanism of action. But the data don't really support it. It's not FDA approved, but I think it's a completely reasonable choice. If you have exhausted the SSRI, this is again clinical opinion, this is opinion, not, if you've exhausted the SSRIs and given really good doses at high doses for long enough time, and someone's really scared to go on clomipramine or can't for medical reasons, I think it's reasonable to try a venlafaxine trial, an Effexor trial, as long as you do it at high enough doses, maybe to 300, maybe even 350, for a long enough period of time. One of the downsides of Effexor is it can cause high blood pressure, so it's not a very useful medication, or people get nervous about using it in patients who have hypertension, and that's something that needs to be monitored. Okay, what do you do if you're on an SSRI and you sort of responded? And that's what most people do. That's what I told you, is on average, that's what happens. Most people have a sort of response. So what are the options as a psychiatrist you can do then? One is you can just push the SSRI dose. So even though the package labeling says Prozac 60, I've seen 80, I've seen 100, I've even seen 120, okay? I've seen Zoloft up to 300 or 350. I've seen Luvox up to 400. Now again, does this make any sense? No. Is it an off-label use of the medication? Absolutely. If you do this with your psychiatrist, should the psychiatrist be informing you of all these things? Absolutely. And should you do it in a very careful way and monitored and slowly? And if it doesn't do anything for you, should you come back down to the dose you were on? Absolutely. But just so that you know, is that that's what's happening in Manhattan. Okay? And what can I tell you about it? Is I can tell you patients who haven't responded at all to a higher dose, and then you hear the isolated case histories of the patient for whom nothing happened, but once they got to Prozac 120 with 25 milligrams of clomipramine on top, gee, the guy went to Africa and went back to college. You know, and it's very hard to evaluate that sort of data, but I don't, my attitude, even though I'm a clinical researcher, is the goal is what works, right? What works that's safe. You know, and unfortunately in the pharmacotherapy of OCD, once you've gotten past what's FDA approved and what's evidence-based, that's where you are. And I think the most important thing is to educate yourself, though, so that if you're out in that outer sphere, whatever you're doing is done safely, is done wisely, and is done in consort with your treatment provider. So you're not doing these things on your own, okay? So one thing you can do is push the SSRI dose. Obviously, if you push the dose, you can get more side effects, you know, so what's the second thing? And this I'm going to hammer, which is add EXRP. So again, the study I showed you showed that intensive exposure and ritual prevention, when delivered and supervised by experts, it was intensive with what I mean, 5 days a week for a month, it's boot camp. Supervised by Edna Foa's group, boot camp supervision. I mean, this was very intense therapy. It beat clomipramine. It beat clomipramine to doses between 200 and 250 milligrams at 12 weeks, okay? The problem is obviously not everyone can do it. And that's a whole other thing which I hope we get a grant to study, because that's the thing that I would like to study next, which is you have this great treatment, but half the people can't do it, or do it partially but can't do it fully. Is there something we could do as providers to help them go all the way with it? Don't have the answer to that, don't have the grant, but anyway, what can you do with an SSRI partial responder? Find them or give them good EXRP. I think it's very useful for patients to start by reading Edna Foa's book, Stop Obsessing. There's a new edition out. It's cost something like $13 or $14. Again, someone should be educated about what it is completely before they start, because they're going to have to wrap their mind around doing this not just with a therapist in session, but doing it as lifestyle exposure. This is about trying to change how they go through their life, and it is not easy. If you've been doing something one way for 30 years, now we're asking you to sort of shift how you handle an obsession and a compulsion. It's like changing a diet or exercise program. It's not an easy task. I appreciate that. Edna Foa and Reed Wilson, I think, is her co-author on it. Amazon has it. I mean, there are other wonderful books, too. I think I think Gail Skedeke has a wonderful, there are other wonderful books, but that one I think of because it's $13, and you can get it at Amazon, and it outlines the program. Okay, what else can you do? So you push the dose, you add EXRP, you add other medications. So this is what I'm going to go through now. What do people do in terms of adding medications? And now I would say you're not out in the stratosphere yet. You're not out in, gee, you're just experimenting with your psychiatrist. This is the zone. Uh-oh. Uh-oh. Yes. Okay. I gotta go quick. Sorry. Okay, so there's, I won't try to speak quickly, I'll just try to sort of jump through some of this stuff. Anyway, the bottom line of it is you're now sort of in the mid-zone, which is there's some data for each of these strategies, okay? So adding clomipramine, oops, that's adding EXRP. Oh, and that's the study, which is showing you Y-box scores over here. Well, those came out funny. That's the assessment point, 0, 4, 8, 12 weeks. You see what happens to patients who get placebo. You see what happens to patients who get clomipramine, you want the lowest Y-box score you can get, and you see what happens to patients who get EXRP alone or EXRP with clomipramine. Okay? Those are though in patients who don't have comorbid depression. Okay. Adding clomipramine to SSRIs, it's a strategy that's currently being used. You have to use it very carefully. There's sort of a couple case histories. There's one report about it. The concern is that the SSRIs, some of them can block the metabolism of clomipramine. So you can get bad toxic effects from the clomipramine if you don't add it very slowly and go up slowly. So this is a strategy that's being used. There's no randomized controlled trial about it. If you do it, you want to be very cautious and careful, and you want to make sure that your psychiatrist is really paying attention to what you're doing here. Then there's adding dopamine blockers, and there's a whole list that have been tried. There's a whole list of new agents, Haldol, Risperdal, Zyprexa, Seroquel, Geodon, Abilify. Why are we concerned about doing this? Antipsychotics can have terrible side effects, which include tardive syndromes and neuroleptic malignant syndrome. They occur in a small proportion of patients, but if they occur, they're bad. So for example, tardive syndromes where people can get permanent, lifelong movement disorders that never go away. Okay? Neuroleptic malignant syndrome can kill you if not found early on. So these are medications and yet, there are two of them for which there are randomized controlled trials showing the efficacy in OCD patients. So Haldol was the first study, and then Risperdal. And on average, I won't go through the details of this, is on average I'd say about half of patients can respond to a little low dose of one of these medications. And again, what's the response? 25 to 40% reduction in symptoms. So, but you should see that within the first 2 weeks. So what I say, and Haldol these days is not used because it has a higher rate of those tardive syndromes and neuroleptic malignant syndrome. That's a first-generation antipsychotic. Risperdal and the next two on my slide, Zyprexa and Seroquel, are all called second-generation antipsychotics, and they're thought to be safer. That does not mean safe. So what I say to people is, this is a reasonable strategy. If you have terrible OCD, and you've tried behavioral therapy, and you've tried SSRIs, and you've tried clomipramine, this is not a there's evidence for this strategy. And we've seen people who've been enormously helped by this strategy. However, it should be tried. After a month, if it's not doing anything, it should be removed. Because I see young people who are stuck on these medications, and no one ever takes them off of it. It never did anything for them, they never get taken off of it, and they get put through life as though they're psychotic. Because when a psychiatrist who doesn't know anything about OCD sees a patient on an antipsychotic, they assume he was once psychotic, okay? So again, now Zyprexa and Seroquel are now being used more than Risperdal even though Risperdal is where the data are, meaning there's a randomized controlled trial, and there aren't yet for Zyprexa or Seroquel, but they're in process. But the reason why Zyprexa and Seroquel are being used more often now is because it's thought they might have a little bit even lower risk than Risperdal for neuroleptic malignant syndrome or tardive syndromes, okay? Again, low doses and trying it. Let me keep going. Then there's a whole bunch of agents that initially looked promising, but when they got studied in randomized controlled trials, don't look like they do anything for OCD. These include lithium, Buspar, Klonopin, T3. Then there's studies which are very small studies, not sure what they do, Pindolol, Inositol. It's not to say that lithium can't be very helpful if you've got a mood disorder and you need to augment your antidepressant response. It's not to say that Buspar can't help you if you have generalized anxiety. It's not to say that Klonopin can't help you if you have comorbid social phobia or panic disorder or generalized anxiety disorder. What I'm saying here is that adding these medications on just to treat the OCD, randomized controlled trials don't support that strategy. Again, doesn't mean there aren't case reports of patients, isolated patients, who have a good response to it. It's not an unreasonable thing to try, but now you're starting to get out in the outer stratosphere. Moving outward, which is all the anticonvulsants or mood stabilizers, Tegretol, Lamictal, gabapentin, Neurontin, Gabatrol, Topamax, all of this stuff, we don't have a clue whether it does anything in OCD or not. Opioids are being used, both morphine and tramadol. Very unclear whether that's effective. Okay, so that's partial response. Now no response. What do? No response or side effects, so you can't actually be on SSRI. Again, you're going to see me say try EXRP. Try another SSRI for the reasons why I told you. Try clomipramine or venlafaxine. And then you're down in completely experimental monotherapies, which include intravenous clomipramine, monoamine oxidase inhibitors, neurosurgery, deep brain stimulation, meaning you shouldn't be there unless you've actually had a really good trial of several SSRIs, clomipramine, venlafaxine, and a really good trial of EXRP, from my opinion. Just a note to say, don't forget about comorbidity, though. Everything I've said to date is about treating OCD itself. Most people with OCD have a lot of comorbidity, including depression or anxiety. There are good reasons for these medications, these other medications, if you have comorbid disorders. So in particular with depression, a lot of depression in OCD doesn't respond to just the serotonin reuptake inhibitor, and there's some evidence to suggest that adding a norepinephrine reuptake inhibitor can boost the antidepressant response, and it's very important to treat depression in OCD because depressed people have a hard time doing cognitive behavioral therapy, for example. And most patients I've seen, when they get depressed, their OCD gets worse. So you've got to keep on top of treating their depression, as well as treating their other anxiety disorders. Social phobia is very common, comorbid in OCD, and can really interfere again with cognitive behavioral therapies. So now, I know I'm still running over. This is how long to be on an OCD medication. The bottom line of it is relapse rates look to be about, they're all over the map. They range from 4 to 89%, depending on the study, which really has to do with the methodology, I think, not the underlying reality. What I know is that when we took patients in our study who responded to clomipramine, taper them off the clomipramine and watch them for 12 weeks, half of them within 12 weeks returned to their baseline OCD severity within 12 weeks. So the good news is half didn't, but it was only 12 weeks. And the bad news is half did. So unfortunately, I say to people, it is an illness which one should anticipate being on medication, possibly for life, unless you can use cognitive behavioral therapy to do it instead, which is another plug for cognitive behavioral therapy. This is current brain models. This is saying how do our meds work. The bottom line of it is, we don't know. When people thought that it was enhancement of serotonin was what would be good in OCD, they tried all these other things, Buspar, lithium, Pindolol, to enhance serotonin, but they didn't work. So the bottom line of it is, yes, we know serotonin reuptake inhibitors inhibit the serotonin transporter, and yes, we know that the dopamine blockers block the dopamine receptors, but how that leads to symptom resolution, we don't know. Okay, summary. Psychotherapy with exposure and ritual prevention. Pharmacotherapy. First line are the SSRIs. If there's no response, try clomipramine or venlafaxine. And if you have a partial response to an SSRI, push the dose, add EXRP. I can't see what my next thing is, but it must be add some of the antipsychotics and then possibly add clomipramine. And the importance of treating comorbidity. And this is, I have two more, this is it. This is, just so that you know, is a study we're currently doing at the Anxiety Disorders Clinic, is for OCD patients who are on a serotonin reuptake inhibitor, any of them, who still have residual symptoms, which is most. And we are trying to study rigorously whether adding exposure and ritual prevention on top will help people. So it's a study where people come in, they're on their SRI already, we don't take them off of it, we keep them on it. They can also be on concomitant medications if they need be. They get randomly assigned to 2 different types of cognitive behavioral therapy. One is exposure and ritual prevention, another is a stress management therapy.